Okay, well, welcome to the AHAP webinar. This is Christy Sanger, and I am one of the co-directors at the Association of Healthcare Emergency Preparedness Professionals. We're excited to have you join us today for our special edition webinar of riot control agents, what hospitals need to know. We have presenters listed here. Dr. Ziad Kazi is from Georgia, and he is the Associate Professor of Emergency Medicine at Emory University. He also is a board member of ACMT, which is American College of Medical Toxicology. And he is the American College of Medical Toxicology, for those of you that don't know, has been doing COVID-related webinars for quite some time now. They do them every other week. And so if you haven't checked those out, we strongly recommend you check out those webinars because they are free and they are very informational and relevant material to all of what's happening with COVID. Dr. Tharwat Al-Zahran is the Assistant Professor of Emergency Medicine and Medical Toxicology and Co-Director of Toxicology Services in the American University of Beirut in Beirut, Lebanon. And Dr. Ritarag
Othong.
Thank you so much. Is the Residency Program Director at the Department of Emergency Medicine in Vahra Hospital in Bangkok, Thailand. So we are looking forward to hearing all of your professional knowledge and expertise on this topic, as we know that this has the potential to really affect us in the upcoming weeks and months, if it hasn't already. So thank you all for being here. Dr. Kazi, I'm going to let you go ahead and share your screen now.
Thank you so much.
Thank you.
Assuming it looks good on your end. Very good. Thank you. First of all, I would like to thank your organization, AEHP, for the kind invitation. It is our pleasure to be here today, the three of us. It's also a pleasure for us to build on the recent partnership between the American College of Medical Toxicology and AEHP on the COVID-19 webinar series that we are partnering on. We appreciate your participation and value your expertise as a group, and look forward to actually having one of your members as one of our speakers in the near future. Today, the topic of the presentation is riot control agents, what healthcare facilities need to know. We've given similar presentations, the three of us before, but we promised today ourselves and Christine to go ahead and adapt it really for your specific audience interest. And I hope we'll be able to achieve that. My background in this area is due to my training and work in emergency medicine at Grady Hospital at Emory University, as well as the Georgia Poison Center, which receives these exposure calls as well to the Poison Center. I'm also a board member of the American College of Medical Toxicology, which is currently preparing a position statement on the same topic. And I'm the president of the Middle East North Africa Toxicology Association, that deals with enhancing the care of poison patients and preventing poisonings in the Middle East North Africa region, such as Beirut, where I'm actually an associate professor adjunct at the American University of Beirut Medical Center, where I co-direct the toxicology service with our co-presenter, Dr. Tharwat Al-Zahran, that I will talk about in just a second. I'm also a consultant for the University of Alabama at Birmingham, NIH-funded Counteract Research Center for Excellence on arsenicals, which could also be relevant to our discussion today. I wanted to bring to you also real life experiences with these injuries. I personally have not had any significant personal clinical experience with tear gas injuries. I could count on one hand the cases that I've actually cared for directly at my Poison Center, as well as at the ER at Grady. However, Dr. Tharwat Al-Zahran and Dr. Ritarag Othong had the opportunity to respond to these events, these mass casualty incidents in their own emergency departments in Beirut as well as in Bangkok. If you remember, there were some incidents in Bangkok several years ago that really engaged Dr. Osong in this response, and that was kind of the beginning of his involvement in this field. And then Dr. Zahran as well, same with the riots in Beirut. Both Dr. Tharwat and Dr. Ritterak, he goes by Top, by the way, T-O-P. It'll be easier when we converse today. Both of them completed a medical toxicology fellowship at Emory University, our program, and then moved back to their home country to play a leading role in the development of the field in their country. None of us actually have any conflicts of interest to disclose related to the presentation, and I hope you'll enjoy it. There's a handout that's available to you, and I hope we can generate some questions at the end. I think we're going to try to keep about 10 to 15 minutes for Q&A. Please feel free to chat these questions into the chat box right now, and we can go through them at the end. And if we don't get to your question, we will basically respond to those by email, hopefully after the webinar. This webinar will basically allow you, after you attend it, to describe to your colleagues and to others in your hospital what chemicals are used when we hear about tear gas and crowd control agents. It will also allow you to discuss these injuries that can result from the tear gas exposure, and what do you do in the emergency management of these victims. We'll focus primarily on the hospital, as we already mentioned. Now, it goes without saying that we've had a lot of protests in the US recently. These were all galvanized by multiple social, political, events and incidents that have occurred. Nevertheless, these protests have also been subjected to the use of riot control agents, or TEARGAS, as you see in this New York Times article from June 16, 2020. Essentially, this has been really unprecedented amount of incidents where these chemicals have been used in these protests. As you see here in this incomplete map, of course, this is what the New York Times was able to collect in terms of the sites that used these chemicals in June 2020, unprecedented use of this at an unprecedented time. And nevertheless, we all been living in a pandemic for the last 10 months that has transformed our lives upside down. And, protests and chemicals being used have certainly increased the concerns about increasing viral transmission in these crowded areas where people are, shouting or screaming. Again, we've just recently heard Dr. Fauci emphasize again the release of virus particles when you do things like sing or shout. Certainly at a protest, you're doing that. Of course, you also have a tendency in a protest in the heat of June to remove your mask, which again increases the risk of transmission. You are in a crowded area. Although you are outside, you are potentially in a crowded area and at times potentially poorly ventilated location. So certainly all of these activities theoretically will increase the risk of COVID-19 transmission, although we have not been able to really epidemiologically link the two. Certainly they make sense. And if you, on top of that, use chemicals that are irritant in nature, what do you expect the protesters will do? They will potentially, remove their mask. They will potentially start coughing, which increases the viral transmission. And they will also potentially rub their eyes, which will also increase transmission. So all of these activities have led to several professional organizations to maybe appeal to the law enforcement agencies to potentially decrease the use of these chemicals as a riot control method. This has not come out of vacuum, actually. If you look at the literature, scientific literature, and you try to see if there's a increased transmission of viral infections after exposure to these chemicals, you find a couple of epidemiological studies. And they're not the highest quality of evidence that I could quote to you today, but there are a couple of studies, primarily in the military, where the military are usually during their training are exposed to these chemicals. And there were some reported increase in infections like influenza, of course, not COVID-19, but the regular influenza or respiratory illnesses, specifically respiratory illnesses, what they look for in these studies after participating in a training, which led to the assumption that potentially just the exposure to the chemical itself can increase viral transmission. But again, this data is not very science-based. These are epidemiological descriptive studies that I'm quoting here. Now, in general, though, we do see these chemicals used, and we do see reports of exposures to these lacrimators reported to the poison centers. And in general, they are not very severe in their outcome. As you see here, about 4,000 cases have been reported to the National Poison Data System of Poison Centers in 2017, over I think a decade in this study. But 25% of these cases ended up going to a healthcare facility, but the majority actually were not at a healthcare facility, and no deaths were reported. I would like to just to clarify that I'm not sure about the duration of the study. I'm sorry, I don't have that in my mind right away, but I can go ahead and pull that study and chat the duration of these 4,000 reported exposures in this National Poison Data System study. So to bring you more details about what these injuries would look like in your emergency department, I think it's really a good idea to bring in Dr. Tharwat Zahran, who will actually go in at this point and describe to you the clinical impact on your emergency department from an incident like that in your city. For that, I hope Dr. Zahran will share her screen and take it over for the next 10 minutes.
Hello, can you see my slides?
We can see a slide and we can hear you, Dr. Tharwat.
Okay, perfect. Thank you, AHEPP, for hosting me, and it's my pleasure to share my experience. So Lebanon is a Middle Eastern country and has been lately facing a huge economic and political crisis, which crippled the whole country. On August 22nd, 2015, the Lebanese people protested in central Beirut due to the garbage crisis at the time, and police fired rubber bullets and used tear gas canisters in attempts to disperse the crowds, which resulted in multiple casualties who presented to various hospitals across central Beirut. And unfortunately, again, on October 17th, 2019, another wave of protests began. And due to the economic collapse, and the Lebanese security forces again resorted to the use of rubber bullets and tear gas to disperse the crowds. And protests continued at the time until February 2020, resulting in hundreds of injured victims seeking care at various hospitals. And since the American University of Beirut, where I practice, is in close proximity to the site where people were protesting, ABMC was one of the major destinations for the injured victims. To better assess this is the Riot launcher, an example of what has been used by the law enforcement. And to better assess the burden, Ziad and I did a retrospective cross-sectional study to look at all the casualties, the clinical presentation, the medical outcome, and to assess the economic burden. And this is some of the photos, an example of the tear gas canisters that were used in the latest protests, and it is CS gas. After we assessed the patients, the data, we had 313 patients, casualties, that were seen at our emergency department. And the mean age was around 30 years, with the majority being males and from the protesters. Most were stable, and they had an emergency severity score of 3. And EMS was the most common mean of arrival for patients. It's around like 44% actually, and the rest arrived by themselves. In terms of the mechanism of injury, the most common mechanism was direct injury by stones, rockets, tear gas canisters, and projectile objects. When we assessed the influx of the patients, it was actually high, and we had an average of 1 patient every 7 to 8 minutes. And in peak days, we had 1 patient arrive every 2.7 minutes. And here it's very important to have a proper communication between EMS personnel and the ED to better distribute the patients over several hospitals, and to have the triaging and the field treatment by EMS can alleviate a lot of the burden on the emergency of the emergency departments. When looking closely at clinical presentations and exams, we had musculoskeletal injuries were the most common injuries, followed by lacerations and head, ear, and eyes and throat injuries. And it's important to increase your staff, to stockpile your AD with cast equipment, with suturing kits, and to also have orthopedic and ENT on board, in addition to the operating room being activated. The majority did not require laboratory testing. However, almost 77% required imaging, including X-rays and CT scans. And here it's also important to communicate with the radiology personnel to increase staff, to expedite the reading, and so that you can move the patients quickly. And around 10% had major findings. And the most common procedure in the ED was laceration. And the most common medications included pain medications, tetanus vaccinations, in addition to bronchodilators. And it's essential to so that you prepare your AD and stockpile the most common medication during riot injuries. In terms of disposition, the majority were treated and discharged from the emergency department, and the rest were, some were admitted to regular floor, few admitted to critical care units. And among those who required surgery, we had almost 8 patients who required surgery. And the most common included head and neck surgeries, in addition to extremity surgeries. And although the mortality rate, we did not have any mortality in the riot-related injuries in 2019, but in the prior one, we had around 1.1% mortality, but maybe because the people were more prepared and they had helmets, they had goggles and masks, given that they are more experienced now. But actually, the injuries were significant. We had comminuted skull fractures, subarachnoid hemorrhages from the tear gas canisters, epidural hematomas, complex facial fractures, frontal fractures, and the ruptured globe, in addition to retinal detachments, tripod fractures, also multiple extremity fractures requiring operation. We also had scrotal injury, and one of the patients, 19-year-old, required orchiectomy, in addition to other spinal injury. Though we had a lot of chest and wall injuries, but none of our patients had lung contusions or pneumothorax. In terms of the supplies used, the most common supplies include suturing kits, as I mentioned, IV catheters, tubing sets, face mask, and bandages. This is important when you assess the presentations, so that you can stockpile your AD with these supplies. The cost among the inpatient reached up to $56,000, and this is a huge economic burden in a country that's already, its economy is already crippled. For the outpatient, the cost was around $124,000, and this is around $414 per patient. So why it's really important? It's important to assess the presentations of these patients and to have a proper prepared disaster plan that's tailored to your institution capabilities, because you never know when other natural disasters or other disasters can occur. And this is exactly what happened with us in Beirut, where we already had multiple protests, multiple victims, a huge hospital and economic expenses. And then we were faced with the Beirut blast and the Beirut bomb, and our ED was flooded with casualties. Given our experience, we already had a prepared disaster plan that's tested frequently, so we were able to manage thousands of patients. This is the Beirut port before the bomb and after the bomb, unfortunately. This is what happened after the halo, after the blast. And remember also that sometimes even your own hospital could also have casualties from healthcare personnel, or your AD could be damaged, with which what happened with us. This is the outside of our emergency, where patients started flooding and their family members. And we actually had 6,000 injured and 162 dead. 300,000 were left homeless, and we received around 400 patients in 4 hours just in our emergency department. And thank God we had a prepared disaster plan, and we were able to manage all those cases who were really sick and significant. So what are the lessons that we learned from our experience from the riot-related injuries? Although they are promoted as less than lethal weapons, riot control agents can lead to significant and permanent injuries. It's crucial to have a predetermined disaster management plan tailored to your institution to deal with the mass casualties. Maintain stockpiling of medications, of supplies, and train all medical, surgical, nursing, pharmaceutical, and IT teams, because also we do use EPIC, but during disaster, you have to resort to a different plan where the patients are already given numbers. So even the IT need to test their plan frequently. And proper coordination with EMS is crucial to disperse the load and the communication with other departments as well. And the improper use can lead to a huge financial burden on any institution. Thank you. I'll turn it now to Ziad. Ziad, can you hear me?
Thank you, Sarah. Thank you so much. I want to salute you and other healthcare providers that responded to this horrific disaster in Beirut. I happened to be there as well, and I had the honor to work in the emergency department for the day shift following this disaster. And what Sarawat did not mention, due to just to be brief, she actually ended up caring for another mass casualty incident of involving protesters that occurred a couple of days after the explosion. Because after the explosion, protesters went to the street again and demonstrated inspired and incited by the horrific disaster that happened in their own city. And that led to another couple of hundred casualties coming to the emergency department at the UB in one night, I believe. And I think Tarawat was there as well. Certainly, her presentation emphasizes that the injuries are complex and the agents are complex. It's not just chemicals, it's also a lot of trauma that you need to consider from these, riot control agents or these less than lethal measures that are used. But I want to focus a little bit more on the actual chemical side of things. Being a toxicologist, I want to just, share with you some of the information that will be useful in your response. The first of which is that they're called tear gas, but they're not really a gas. They're actually a powder that hydrolyzes in air with humidity and water and releases the acid that causes the irritation, or releases the chemical that causes the irritation to your mucous membranes and to your respiratory tract or your skin. The number of chemicals that are used for this purpose is large, but the most famous ones are CN, CS, CR, DM, OC, and PAVA. Now, some of these are no longer used. For example, CN is much less commonly used. This was the first chemical that was used in the early 1900s, around World War I. It was supposed to be maybe a chemical weapon, but then moved to be used as a riot control agent. That's been replaced, of course, with CS and OC. Primarily in the US is what we use as OC. But want to point your attention to other ones like CR and DM. DM is of particular interest to me because it's an arsenical. And like I mentioned earlier, I work with the UAB's Arsenical Research Center funded by NIH to look at antidotes for arsenicals. And PAVA, is another one of these chemicals. But when you think about the US, what we use here in law enforcement is OC as well as CS as well sometimes. And then, of course, with the US, we use a lot of projectiles that I will not cover today. I will just cover the chemical agents that are used. When you are planning to receive these victims, remember that these are not always sudden, because you know that the protests are happening, and preparing for the arrival of victims should be possible. Think about who are these victims, the size of the protest, the size of the group that may arrive to your emergency department, the location of the protest, the environment where this protest is occurring. Is this somewhere close by to your emergency department, or is this far away from your emergency department? The closer they are to your emergency department, the more likely you will get the victims, and the more likely you may get victims that are still contaminated with the tear gas powder on their body. Also think about the location of the protest. Is it well ventilated? And do they have an easy egress? Are they able to exit? There were some reports in the recent protests where protesters were trapped between a bridge or a highway and the law enforcement, and were not able to basically exit the area away from the chemicals. And of course, think about what is the chemical, how is it being delivered? Is it a canister? Is it a pepper ball that contains OC inside of it? Is it a machine that is releasing the gas? So aerosolization machine. There are more than one method to release these chemicals to try to disperse or control a crowd or a protester crowd. Be alert to the possibility of trauma, and look for these projectiles that can be easily missed on initial rapid physical exams that you perform. But in general, you have to think about 3 body systems that are affected, excluding trauma: the skin, the respiratory tract, and the eyes. And these chemicals vary in some of their potency, the time to activation, which is important. How quickly do they actually cause the symptoms? They vary. They're all quite rapid, but some more rapid than others, and the duration of the action. Those are the 2 things I would like to highlight here for you on that table. The duration of action is important because, like I said, many of these are self-limited. And when you care for these on the scene, you may avoid an emergency department transport. Now, remember that in Lebanon, where Dr. Tarwat works, there's very little emergency medical services systems in place, and very little being done on the scene. So all of these end up going to the emergency department, which kind of biases her data a little bit, of course. But consider that compared to the US, where even though we do have EMS systems, still about 80% of your victims will arrive to you without EMS. So appreciate these differences in the time to activation, the duration of action, the potency of these various chemicals that I listed. Think about your victims. You know, where are they located? How many are there? And who are they? Are they asthmatic? Are they children? Are they adults? Some of the characteristics that really increase vulnerability to the effect of these chemicals are lung diseases like asthma, chronic obstructive pulmonary disease or COPD, emphysema, cardiovascular disease like hypertension, coronary artery disease, those with extremes of age, young children, elderly, those with existing ocular diseases, or those that are wearing contact lenses may develop more severe injuries. The respiratory effects of these chemicals, like I said, are irritant in nature, primarily of the nose, throat, and chest. They are rapidly going to cause the symptoms as they hydrolyze and release the acid. They react rapidly with water because they're quite water soluble, and that makes them rapidly cause the burning in the throat, the nose, the eyes, the cough, the difficulty breathing, which can exacerbate your existing asthma or chronic lung disease. The good news is that you rarely see severe complications, except if you have some case reports out there of people that had upper airway compromise that was rapid, those that developed severe pneumonitis and acute, kind of like an adult acute respiratory distress syndrome or ARDS, severe pneumonitis and pulmonary edema requiring mechanical ventilation, oxygenation. Those can occur, although they are rare, and may occur in more likelihood with those with existing lung disease. The potential long-term complications of these exposures is not well studied. We know that those exposed to chlorine, for example, in mass casualty incidents or releases like Graniteville, South Carolina, train derailment, can develop something called reactive airway dysfunction syndrome. That has been less described from the exposure to these riot control chemicals. The cutaneous effects, again, are mild burning sensation, that will get worse if you have a moist skin, which is not unusual when you're protesting, and if you are in a high temperature environment with high humidity. These can evolve to rashes, blisters, and they look like second-degree burns potentially. This is certainly with heavy exposures where you develop these vesicles and reddening that can basically occur 14 to 16 hours after the exposure, especially if you don't wash the skin and leave it with the chemical on it. There are also some allergic manifestations that can occur delayed after the exposure to the chemicals. This will maybe like occur 24 hours later and are often described as dermatitis, allergic dermatitis, or acute generalized pustulosis by the dermatology colleagues. The eyes are also potential targets of injury. Most of these are minor and manifest with burning and tearing of the eyes. You do have the patients wanting to basically close their eyes, just develop this blepharospasm from the pain and the burning and the conjunctivitis that is occurring. In the extreme cases, you may see actual lid swelling, eyelid swelling. And with some of these severe exposures, you may have some long-term consequences, like a corneal epithelial defect that requires a couple of weeks to heal, of course. And, in some rare cases, especially with agents like CS, which is less commonly used now in the US, you can have scarring of the conjunctiva. And that can result in elevation in the intraocular pressure, which we call glaucoma. To care for these, you have to certainly remove the contact lenses, blow air or irrigate the eyes with saline or water, get your exam done properly with your slit lamp, and apply topical antibiotics and mydriatics to decrease the spasm of the ciliary muscle that causes the pain. Oral analgesics are certainly warranted here because of the severe pain that some of these patients may develop. But please do not use the topical anesthetics because they can lead to worsening of the actual corneal epithelial defect if not used properly. You can use those topical analgesics for your exam in the emergency department, but it's not recommended that you prescribe these as an outpatient. For analgesia, you should use oral medications. We're all familiar with using the Morgan's lens in the US. We use the Morgan's lens to irrigate the eye with plenty of saline or water, followed by the slit lamp exam. And don't forget to get your visual acuity exam. The key here for managing these is removing them from the scene, of course, preventing secondary exposures to yourselves, your staff, with the decontamination and PPE. I will not talk too much about that because that's really what Dr. Othong is going to share with us from his experience. He will talk about the decontamination and your supportive care. I do want to highlight a couple of points regarding the pre-hospital considerations. Although I know you are more in the hospital environment, but the paramedics have to consider various issues such as their staging area and if it's safe from the protester violence, for example, if it occurs, or from the actual chemicals that are being used. So how do you do that, and how do you communicate with law enforcement, and how do you control rumors about the protest and what's happening next is going to be a challenge for our EMS personnel, who are also supposed to try to protect themselves by donning the appropriate personal protective equipment and trying to decontaminate these patients on the scene. And then finally decide if they need to transport these patients to the appropriate nearby facility. For that, I would like to turn it over to Dr. Othong, who is going to share with us his experience and the lessons he learned when he had to respond to the demonstrations in Bangkok. Dr. Othong, would you mind sharing your slides, please? Dr. Othong? There he is. You want to do a sound check, please?
Hello, yes. Let me share the slide.
Okay. Yeah, we can see your slides. You might do slideshow.
Okay. Do you see it okay?
Yes, we do, and we hear you well. Thank you. I'm going to go on mute. Thanks, everyone.
Sorry about that. I will start from this slide. Hello, everyone. Thank you, Dr. Kasi, for the introduction, and I would like to thank the committee for the invitation to give this talk. I'm going to talk about the riot control agents with our past clinical experience from protests in Bangkok. So what kind of tear gas that was used in Bangkok for the first time? So these some pictures that media captures from protests in many times. You can see here, all of them, they are CS. This happened to my hospital the first time, and actually tear gas was used in Thailand for the first time as well in August, on August 29th, 2008. At the time, none of us knew what it was, and we only have little knowledge on how to manage patients with contaminated patient and how to prepare our ED. In the night of 2008, when the situation occurred, it occurred about 7 p.m. At the nearby emergency medical technician carried 19 contaminated victims who were most symptomatic to my hospital, which is the Vachira Hospital, by ambulances without decontamination. You can see in the picture, this is happened in front of the House of the Representatives. And I will show you the map of my hospital and the scene. You can see in the picture, at the point A is the House of the Representative, which was the scene of the tear gas that that released to the protesters. And point B is my hospital. Point A to point B is just 5 to 8 minutes. So it's no way that my hospital can prepare anything to decon the patient. So what happened later? After the EMT drop off those patients at the ED front door, our porters, the hospital porters, and also the EMT, they brought all of the patients inside the building into the triage area. At this triage area, we did a little bit of talking about if the tear gas is used, what would we do, but it's not seriously about how to manage the patient, because we thought it would not be used at the time, and also it's never been used before in the country. But we discussed about that, like if the patient comes in because it's a gas, so we just disrobe the patient, the gas should be dissipated, it should be okay. So for the male patient, we ask them to take off their clothing at the triage area, but for female patient, because it's too much exposed for them to take off their clothing at the triage area in the same area with the male patient. So we ask them to move to the bathroom nearby and take off their clothing in the bathroom and ask them to take a shower at the same time. But none of our healthcare providers inspected them if it's thoroughly washed, and then all of them were sent back. All of the female, all of the female patients were sent back to the triage area where it's already contaminated, and all of these patients were sent to the treatment area according to their severity, the yellow one, the red one, and the green one. At the time this happened, healthcare providers wore plastic aprons, gloves, surgical masks, and protective glasses. Only some of them, they used goggles, so mostly it's level D PPE. So what happened? About almost 100% of our healthcare provider got the secondary contamination from tear gas that brought in with the victims. So 100% of EMT and also nurses, they were secondary contaminated. And about the symptoms of secondary contamination, what are they? 100% of them, they had eye burning and lacrimation, nose 68% nose irritation and rhinorrhea, that's followed by skin burning, coughing, chest tightness, dizziness, nausea, vomiting, sore throat, and also myalgia. So all of them had to work in the ED until the situation ceased. So they have to help themselves. They have to wash their eyes and use tetracaine to reduce the pain in their eyes, something like that. So we have learned a lot of things at that event, and it only happened once because we have a lot of lesson, and then we improve all of the problem that we experienced for. So we know that tear gas is not a gas; it's a solid particle, as Dr. Kasi already pointed out. So only disrobing those patients is not enough. They need wet decontamination as well. And also setting up the decon facility outside the ED is the best option. You should not set up the decon facility inside, because even if a solid particle is small, it can dissipate and also spread inside the building, as happened to my hospital. And also you need to make sure that you manage about the patient traffic. It should be one way. If you in our situation, we send the female patient who were decontaminated already back to the triage area where it's already contaminated again, and then they get contaminated again, and then send them to the ED, inside the ED, and then spread all the to all of our staff. Usually, protests in Bangkok, it took several days or weeks for turmoil to escalate to the climax, and tear gas would be employed. So, and also because we thought that most of the protests happened not far from my hospital, like at the House of the Representatives or the near the Parliament. Both of these places, they are close to my hospital, like within 10 minutes. So we thought that pre-set up the decon facility while situation escalating is the way to go for us. And this is the traffic that we improve after the event. In the first place, you can follow the pink arrow. This is when the normal patients come into my hospital. They just go through the ED front door, and that happened once with our tear gas exposure patients. After that first situation, we changed it and to transfer all of the patient to the back, drop the patient in the back, and we set up a decon facility on the back of the ED, and then we wash all of them before they are clean, and then we send them inside the ED, and we change the triage area from the front door to the back door. And however, we still allow normal patient without contamination, for example, heart attack patient or asthma patient, to go to the front door as usual. So I have received many questions. Do we need wet decontamination? Can we do just dry decontamination? As I said before, CS gas actually is not a real gas. It is a solid particle, small solid particle. And CS gas, even if solid particle, is not soluble in water. However, it can be hydrolyzed in water. At the pH of 7, the half-life of the CS gas is about 15 minutes at the room temperature. However, it can be hydrolyzed rapidly in alkaline solution at the pH of 9. The half-life can be reduced to just 1 minute. So it is important to decon the patient with water and soap, and so that the patient can have can get better sooner. However, initially they will probably feel more pain from the burning with the soap and water, but it will dissipate rapidly if you use enough water to flush all of those chemicals. And also, I would like to point out in Bangkok is many times that when we have protesters, it's not just protester. This is government protester. They label themselves with something like the color of the shirt, like the anti-government protesters here. Here. the government supporter is like in red shirt, and sometimes anti-government protesters, they are in yellow shirt, and you can see law enforcement officer, they are in uniform, right? When you can have any group, any people of each group to come to your ED, the same ED. Sometimes we have seen that they fought each other even inside the ED. So when you disrobe them and then you change their clothing to hospital clothing, that I would like to point out that is a good idea too, because you like unlabel any of them and then they just are in the same hospital clothing. That can reduce the risk of fighting inside the ED as well. And which of the PPE would be preferred? So not glasses, as 100% of our not 100%, almost 100% of our healthcare provider use glasses and they got contaminated. Not apron, not surgical mask. Like to recommend the goggles. I'm sorry, the goggles. However, if you use the goggle, make sure there's no vent on it, because we have seen some of our staff got contamination because the CS powder can go through the vent to contact your eyes and then cause eye burning as well. And if you have enough splash suit, use it. And also PAPR and P100 would be the best choice for you. But if you have limited supply, you may use this kind of PPE. So the surgical gown is okay as well. Sometimes my staff, they don't want to wear the splash suit because it's difficult for them. They are used to wear surgical gown better. So sometimes they use it and none of them got contaminated from the tear gas, because if the gown cover most of the skin, and because it's also prevent water to get inside, it should be okay. And N95 is okay as well. Why? Because the particle size of the CS gas is about 0.5 to 2 micron, but the N95 can filter any particle larger than 0.3 micron. So the N95 is okay for use as well if you don't have PAPR, which is a lot more expensive, or P100. And also, if you are concerned about leakage of the tear gas inside through the N95, these all of the tear gases, they have low vapor pressure. So I think there's less concern about the leakage of the gas inside through the N95 or the surgical gown. And not the powder tear gas, that's what used here. And in the past, the watercolor was used before as well. Watercolor also were used in many countries, like in Hong Kong, in Thailand, and some country in Africa, like Uganda as well. It's actually what it is. So this is from the Royal Thai Police Bureau of Investigation. They posted this over the media, what the watercolor is. Actually, it contains the CS gas as well, and the methylene chloride, which is the solution for the solvent for the CS, and also they add color, methyl violet. Actually, the purpose to use this color water is to label those protesters. So this is our experience the first time in August 2008. And after we learned a lot of this thing and we improved everything, after that, we have got about 300 tear gas exposure and 214 trauma cases from 2008 to 2013. After the first situation, we had no other secondary contamination at all. And for the ED disposition, the rare occurrence of delayed pulmonary edema in patients with pulmonary symptoms had led to some experts to recommend 24 to 48 hours stay in the hospital for observation before discharge, or you can discharge the patient home with the information about the potential of complication, especially for the pulmonary complication. But from our experience, we have seen them usually, if they are not injured from other trauma, like Dr. Chavat pointed out, usually we can discharge the patient home right away. And I could say many of them, they did not go back home. Actually, they went back to the protest. For the inpatient admission, I would like to point out one more thing, that you should admit each group according to their roles in different wards, because we have experience like when we put a protester and government supporter together in the same ward, they fought each other in the wards as well. And for protesters and general public, we would like to advise that giving or providing basic knowledge to the public probably is a good thing to do, because if they know what they're exposed to, what they need to do, and what is the first aid for them, this way can reduce the ED visit and also to prevent ED crowding as well. So this is the poster that the Thai Association for Emergency Medicine provided a few years back when we had many group of protests at the time, and we also posted it on the social media like Facebook or Line. Line is like WhatsApp of that you use in the US, but here in Asia we use the Line application. This is example like what they need to bring to the protest to protect themselves. For example, wear long sleeve shirt and pants, bring another set of clothing for change, bring swimming goggles or face mask, water and plastic bag, just in case they got contaminated and they had eye burning, they can use water to flush the tear gas from their eyes. And if they have asthma, they should bring their inhaler as well. And if the tear gas is released, what to do, like leave scene immediately, be above wind and at higher place, take off contaminated clothing, put them in a plastic bag and seal it, take off your ornament, take off contact lens, rinse water to wash out residue from the eyes, mouth, body, at least 15 minutes, something like that. And do not use lime juice or milk. And tear gas causes irritation such as chilling, red eye, sore mouth, throat. If all not go away within 30 minutes, you should seek medical attention. And also the poster provided some guidance for medical personnel as well. All right, that's what my talk. Thank you so much. And this awesome pictures from the media. They showing they were wearing goggles and they help each other washing the eyes with normal saline. Thank you for your attention.
Thank you, Dr. Otong, for a great presentation. Thank you, Dr. Tharwat. We have a few minutes for some questions. One question that came to you, Dr. Otong, from Keith Hansen. Can you please talk about what did you do to the actual emergency department to clean it up after it was contaminated in the first incident for the actual ER space?
Yeah, that is what at the time all of the staff just stay in there and help all the patient and until they could like admitted all of them or discharge all of them, and then they just clean up all of the ED. Just use the normal cleaning up process to clean up the ED.
And of course, the good news here is that they hydrolyze so rapidly that as time goes by, whatever is there is going to be gone.
Yeah, the half-life of the CS is 15 minutes without anything, but with the soap and water at the pH of 9, it's just 1 minute. So it's easy to clean up.
the one time I was secondarily exposed at Grady was the woman who was attacked by a robber up the street from our hospital at the corner of, literally like 2 blocks away from our hospital. She was attacked and sprayed with a pepper spray. And because of her proximity to Grady, she literally just arrived within minutes of her injury and was not decontaminated. And I walked into the room to see her, and myself and the nurse, we started feeling, some symptoms, some minor symptoms, but still reminded me of the importance of thinking about where did the actual incident occur, and how close are they to you, and what is the likelihood that they still have some powder on their body that's hydrolyzing, in your emergency department if you don't decontaminate it carefully. What about recently, Rituraj? We saw some additional protests happening. Are you seeing more this week?
Yeah, I'm sorry. Did you see the black screen? Okay.
Okay. No, we're still looking at your slides.
Yeah. So protests again occur, but the tear gas was not used this time. There's no trauma. Last week, the police only used the color water once, but it's not close to my hospital this time. It happened somewhere else, far away. It's the same CS. Actually, police sent us the detail of the watercolor actually, and it say it's CS. And the city EMS already prepare for the transport of the patient. They set up the facility around the protest area, like at each point what EMS ambulances will send this patient to what hospital, something like that. They already plan about all of the possibility that could happen, and then they send some of the protests that exposed to the color water to a few hospital around that area. And
then did you?
Yeah.
I was gonna ask, did you want to comment on the field treatment? When you say field treatment, what is being recommended to do on the scene?
Yeah, we again every time protests happen, we know beforehand, and then they set up like in many points around at the perimeter of the protest, like in a tent, and they had first aid people inside those tents. Like they provided like normal saline and some first aid, like they can check like blood pressure, they can check like they can give IV fluid, something like that. Because protests, sometimes they collapse, like they have like syncope, something like that, or somebody had like severe hypertension, they got like dizziness, something like that. So they set up the tents for the first aid, so that those people will not go to the ED and causing ED crowding, something like that. Because most of the like people, they just got just mild sickness, and after they got the first aid, they just go back to protest. Most of them were not sent to the hospital. You can treat them at the scene and release them there, and then you can prevent ED crowding. And they also had like ambulances, and they coordinate for every hospital in Bangkok, when and where and what to do, something like that, when the protests occur.
Good. Again, this is not available, unfortunately, in Lebanon, for example. I think we're over the hour. I'm going to turn it back to Christine here to conclude. Thank you again for everyone, Dr. Otong and Dr. Zahran. We appreciate you staying late. I know it's now 9 p.m. in Beirut, and it's about midnight or 1 o'clock in the morning in Bangkok. I appreciate you doing this after hours. Christine?
Yes, thank you so much to all of our presenters for sharing your expertise and staying up late and helping us with these huge concerns. If there are people that have additional questions, please feel free to put those in the chat box yet, and we'll try to answer those after the session or connect you with our presenters, the appropriate presenter to give you that information. We have recorded this webinar. We will send this out to all that were registered for this. I know this is timely and important information, and I have had much feedback from our audience asking if they can have the recording because they want to show it to their ED as quickly as possible. So thank you guys so much. Thank you all for helping and presenting, and thank you to our audience for taking the time to learn about this very important information. Have a great day, all.
Christine, would you like us to stay or?